identified as that evidence-based person for that day, will read the protocol. And then they will find 4 patients. And so on ventilator-associated pneumonia, it would be 4 ventilator patients. And then you're going to go up and you're going to look at those patients, and they'll probably be in critical care because we don't do the ventilator patients that are on long-term. We only do the ones that are in critical care for this rotation. So you will go and then talk to those patients. You will do you may not talk to them because they're probably going to be intubated. And but you'll go through, and according to the protocol, it says how the head of bed should be elevated, how they do mouth care, how they do suctioning, and you're going to find some of the things they don't do at the medical center, and probably not at Greenview either. The high-low tubes. Anybody heard of the high-low tube? Anybody heard of a ET tube? Period. Mm-hmm. Okay, this is good. Okay, and you will see them in person. Okay, but the high-low tube is suctioning right above the cuff. And then you can suction, as typically we do, down through the ET tube. So it takes care of secretions above the cuff, which can then go back up and cause aspiration and lead to pneumonia. And then it does the regular thing where we just suction typically. These hospitals have chosen not to use high-low tubes. They cost more money. But the evidence shows that they appreciably reduce. So again, if it costs $75,000 for each patient that gets pneumonia, and how much do you think the tube costs? You think it costs $75,000? Okay. But it's hard, I always call them the bean counters. It's hard to convince the bean counter that something that costs $3 or $4 more, which they have to up in the hospital anyway, would be effective in reducing costs for the patient. Because they're not looking at the end results of someone with pneumonia. They're just looking about the upfront. This ET tube costs this amount, this ET tube costs $10 more. So what makes this ET tube better? You can't prove that to me. I'm a bean counter. And the beans are not sitting out with me well here.
Until it's one of their family members.
Yeah, and they might change with that, and they'll bring their own high-low tube in. But anyway, the point goes back to we don't use them here, so that'll be one thing you'll find that's not in that's in the evidence that's not being used clinically. So then we're going to look to see, does the patient have pneumonia? And hospital-related pneumonia means that someone has had pneumonia 48 hours after admission. If they come in with pneumonia, it's not nosocomial. They have to have had pneumonia 48 hours after admission. So then we have to figure out, did they do the test to determine if they had pneumonia? So what do you think a test would be? We talked about this under pneumonia. So what was it?
Chest X-ray.
Chest X-ray and sputum culture. Okay. So then you're going to validate, did they have a chest X-ray and sputum culture? So you can see, you go back to the labs and see if those things have been collected. It's not an easy day, but it does help you to incorporate what the evidence is. And then when you bring back, I usually have people put them in little table forms, and then they bring back to post-conference in a little table form the 4 patients they looked at, and 4 sounds puny after you just talked about 6, but again, we're relating the evidence. And you got to go back and you got to understand the evidence, which I do not expect you to read prior to clinical day. You're going to read it when you get there. So bring your glasses, headache pills if you need to, if you read and get a headache, because it's going to take you a little while to work through that. Any questions about evidence-based? Do you guys have input, the 2 of you that have done the evidence-based?
One of the big things is with the evidence-based, you're going to be getting a lot of why we do things. It's scary when you ask a nurse, why do you give that antibiotic before you? Because that's the way pharmacy told me to. Mm-hmm. You need to know why these things are being done, and evidence-based is what these practices are based on. And is it good practice? Big pet peeve of mine. How many of y'all have seen them tape over the cannula?
What cannula?
The IV cannula.
Okay.
Instead of using that opsite.
Why do I care? Just teasing.
It happens, right? What have you just done? Infection.
But you also can't see the hub.
But that's the way it was done. That was the way it was done. So, you're constantly having to adapt to your practice. Who's my LPNs in here?
Most of them are back in that corner.
Hiding in the
and then
corner.
Will's hiding over here alone.
Guys, y'all have it rough, because that was my problem being a paramedic. I had that autonomy in the field and everything, and we did things a certain way, now you gotta switch over to a different type of practice. And it's tough for you guys. And, you know, because you've gotten comfortable in a way to do it. This is the way you learned it. And again, going back to how it's set in your mind, and sometimes you might have to actually make a focus change. Watch it on test questions, big time. Yep.
Are you figuring that out?
Yeah. You know, on evidence-based practice, I was managing an OR. I actually,
At OR.
well, here we go. So I started an ambulatory surgery center, and they were trying the bean counters.
They're
We're
terrible.
trying every way in the world to cut costs. So the ET tubes, you know, you put down, and then you have your ventilator tubing that goes over to the machine, the anesthesia machine. And they wanted to actually save. They wanted to reuse the ventilator part. No. That no. If it's an LMA, they can sterilize those, but not an ET tube. But the point is that is everything the person before has. It's coming out of their lungs, and administration wanted to fight with management, me, on saying that was clean and a proper procedure. And evidence-based practice, you know, you had to pull out your AORM book, you had to pull out everything, and you had to pull out all your knowledge, and you have to fight. And so just be ready to stand up for the right thing, always, no matter what, according to the bean counters, so you say. And there was 1 million of them like that when we opened up that ambulatory surgery center. It was unbelievable what they wanted to do.
They get better salaries.
It stinks. It was, you know, it was everything that came out of somebody else's lungs that they would rebreathe.
How did that work out? How did that situation work out?
I won. So it was evidence-based practice that I won on. So.
And they made a couple changes recently at the medical center with some things that were evidence-based. So I know they're getting ready to really beef up a septic protocol, and I don't know if you are working on a septic protocol out of Greenview, but there's, you know, this thing's been out there now as evidence for a good 8 years, and so it's kind of irritating that it's taking 8 years to improve outcomes for patients when it has been proven for 8 years that this protocol should be in place. But it takes a lot to get institutions to change practice. But the more that you are the forerunner saying, you know, this is what the evidence says, this is what we need to do. And that's why you have several little evidence-based responsibilities in 208 and 209. There's a paper I think you have to do in 208, isn't it? 208 expert. So,
one of the big things you guys have to remember, you know, that thing I was talking about with fresh eyes and things like that, you can say, well, why did they do it that way? You know, doesn't it make sense? You know, how many back injuries are there? You know, but going back to the cost versus benefit, get a hover mat, you can move a 500-pound person around anywhere you want to go with them. God forbid we purchase one of those, we would much rather use draw sheets and hurt our backs. You know, we'd much rather have a bariatric patient turn over on one of our stretchers that they're 200 pounds over the weight for it.
and fall off.
So pay attention to those things and bring them to it. Oh, can I brag on one of my students from last semester?
Absolutely.
Yeah. She was, you know, and anyway, she was, you know, she said, I really, you know, that just doesn't look right to me. Again, something's wrong. The pacer box that was attached to the wires, they were coming out of their body, you know. Anyway, when they went to the bathroom, there was no place to set them. You could set them up on the handrail and it'd fall off, maybe yank the rope.
The pacer box? Okay.
The little external pacer. Oh,
I know what you're talking about.
better. It gets better. And so she had noticed this a couple of times. When the patient would be assisted to the restroom, they would either set it up there and she was scared it was going to fall, or they'd set it on the floor. And anyway, I said, okay. So Randy Villarreal is the 4D manager, and she is awesome with nursing students. She wants to hear your comments and things like that. So Naya and I went, and I said, she's got a good point here. I said, I've never seen it, so, but she'd been observing it. And Randy sent me a picture a few days later. You know those things that they used to stick the blood pressure cuffs in up at the top, the little baskets?
Mm-hmm.
They've installed them in every bathroom on 4D now. Little bitty things.
Why can't you just attach it to the patient's gown? Okay, forget it.
Yeah, we see how well that works. Since everyone pays such close attention taking the gowns off, that's been an issue.
Oh, okay. Cardiac cath lab. By the way, on the rest of the syllabus, it has all the what we consider the off or observational units. I actually don't consider ED, ICU, or CCU observation. You should be in there doing care. Cath lab, cath lab very often, it's according to who's on. You may be sitting in the control booth most of your day that day. That's just according to who's there. Doctors sometimes do not want you in their catheterization room, so that's fine. You won't do that day. Some of them want you in there. They don't want you to touch anything, but they don't mind you being in there. We can't really control what the physician wants at that point, but you can still, the texts are really good, most of them about telling you what you need to know about that experience. But this tells you what your absolute obligations are while you're in those areas. And there does need to be something written up for the cath lab because it's more of an observational experience than it is an actual hands-on experience.